Thank you so much for this opportunity to present our work evaluating the national scale-up of the cradle device and training into routine maternity care in Sierra Leone. I am Alex Ridout. I'm a clinical lecturer at King's College London, and I'm presenting on behalf of a huge team of collaborators across the NIHR-funded CRIBS group. So in Sierra Leone at the beginning of this trial, 1 in every 17 women would die during childbirth or pregnancy. The majority of these deaths related to bleeding, high blood pressure or sepsis were sadly preventable, and at baseline about 1 in 5 facilities didn't really even have a functional blood pressure device, and staff were often not adequately equipped to respond, leading to delays in accessing or receiving quality healthcare. CRADLE was designed with this specific challenge in mind. The device is one of only a handful that is accurate in pregnancy for both high and low blood pressure, costs less than £20 and is robust and portable. It also has an inbuilt traffic light early warning system to alert healthcare workers with any level of training when a woman is in shock or hypertensive and in need of treatment or referral. In 2017, the Cradle device and training package was trialled across 8 countries. Data from Sierra Leone was extremely promising. Introducing the device and intervention into one hospital and the surrounding community facilities reduced the number of women dying by 60%. This generated significant political buy-in and led to this trial, a stepped wedge randomized control trial, to scale up the device and training nationally, step by step, district by district, into the most rural areas of the country across all levels of government healthcare facility. We wanted to determine whether the intervention could be sustainably embedded into routine pathways, and 2, if it could improve a composite primary outcome for mothers and babies by 20%, that being maternal death, stillbirth, eclampsia, and hysterectomy. Over the course of 1 year, over 2,000 blood pressure devices reached almost 700 government healthcare facilities, with 98% fidelity to the protocol. The Central Cradle team trained over 270 Cradle champions, 40 district management healthcare staff, and these team went on to train 2,135 frontline maternity staff using the Train the Trainer model. We co-developed local learning aids to assist with local adoption and embed behaviour change. We prioritised sustainability throughout, with key steps including Ministry of Health leadership, which was absolutely essential, integration into national education and training, and embedding into national and district procurement pathways. So CRADLE has now been integrated into the country's essential equipment list, and very intentionally we've ensured availability of spare parts and local maintenance within the country itself. So what was the clinical impact? Well, here on the left you can see Bundu, one of our brilliant data collectors, working tirelessly to reach the unreachable. We recorded 1,744 primary outcomes out of a population of over 90,000 deliveries. We were unable to show that the blood pressure device was sufficient to impact on our clinical primary composite endpoint. However, we were able to show that significantly more women had their blood pressure and heart rate measured. There was evidence of improved accuracy. But annoyingly, training scores and poor resources such as stockouts of magnesium sulfate or ampicillin were significantly associated with worse outcomes. Importantly, we showed that there was a reduction in maternal death for women referred after use of the Cradle device, and also a significant reduction in neonatal deaths. As you can see here from an article in The Economist, there's been a significant reduction in maternal mortality over the course of the CRIBS programme, above and beyond neighbouring countries. Data collection is challenging within this national step wedge trial, But we have found with individual randomization in CRADLE-4 that this intervention has demonstrated 75% reduction in stillbirth. Our future studies focus on precision diagnosis across 3 continents. In an NIHR-funded global health group, Papagayo was used this different methodology. There's no doubt that universal availability of blood pressure monitoring is necessary to improving outcomes, and we have demonstrated that we can sustainably upscale nationally in this context. Thank you so much for listening, and I look forward to talking to you all at the conference.